and we'll begin. Good morning, Dr. Burnett, or Courtney, as you said. I want to thank you for joining the Glioblastoma Support Network and having a discussion about your journey with GBM. We have a few panelists that will be here to ask questions, and those panelists include Dr. Scott Glickman, Nurse Dee Dee Culley. We also have some other questions from our board members that include Dr. Lori Mins and also therapist Stacy Nelson, as well as members of our organization that follow us in social media. So let's start and hear your story and begin with you.
Wonderful. Well, thank you, Lisa. So hello to everyone watching. My name is Courtney Burnett. I'm a 30-year-old internal medicine physician, and I live and work in Minnesota. I also, as you may know, have brain cancer. My own cancer journey started in January of 2020 when I was studying medicine in Thailand. While I was there, I began to have some strange, unexplainable symptoms and ended up diagnosing myself with a brain tumor. Honestly, the story has only gotten crazier from there. Even as a doctor, a brain tumor diagnosis is confusing, overwhelming, and downright terrifying. Throughout my journey, I've used writing as a therapeutic way to cope with my unexpected diagnosis. I started a blog, which gained an unexpected following, and incredibly, readers from around the world told me they found my words to be inspiring and hopeful. They encouraged me to write a book, so I did. My first book, pictured here, is a memoir called Difficult Gifts, which will be released this upcoming Monday on February 8th. In addition to writing, I found a lot of joy in speaking and sharing my story with fellow cancer warriors, caregivers, and also physicians. So before I get started into my history, I want to thank Lisa and the entire Glioblastoma Support Network for asking me to speak today. I'm very thankful to be here.
We're glad to have you. Thank you so much.
Thank you. I'll keep my story brief, and although I'm a physician, I want to remind everyone listening that I am not a neuro-oncologist or a cancer specialist, so like many of you, I have had to learn a whole new world of information that I never expected I would need to know. I've found that we're all so much stronger when we fight cancer together. So today I just want to say hi, start a conversation, and share my story in hopes that it may also help some of you who are fighting a similar fight. As I said, I'm a writer. So I love words, but I think that pictures often tell the best story. I'll share my story today with you in photos, as well as with short segments from my blog and upcoming book. First, I'll take you way back. I grew up near Minneapolis, Minnesota. My medical journey started many years ago when I decided to go to medical school. I went to the University of Minnesota initially for my undergraduate degree, where I majored in genetics, and ironically performed all of my honors thesis work in brain cancer research. I then moved to Chicago for a time and graduated from Northwestern University's School of Medicine back in 2017. I missed Minnesota and moved back here to complete my internal medicine residency at the University of Minnesota this past year. I've now spent this recent year working as a chief medical resident, essentially a teacher and advocate for students and resident learners. Again, as I mentioned last January, during my third and final year of residency, I was diagnosed with brain cancer. To understand this journey, I'll take you on a virtual trip. Back in January, I went to Chiang Mai, Thailand, where I planned to spend about 6 weeks studying at a large urban hospital. I've always been interested in Eastern and complementary medicine, and I loved the idea of visiting Thailand to work in a traditional and complementary medicine clinic. I planned to learn Thai massage, acupuncture, and some other traditional Eastern methods to supplement my knowledge of Western medical practices. I personally believe a good physician is a well-rounded physician. Science and evidence-based medicine are key components of my practice, but I feel there's more to the field of medicine than science can fully explain. Medicine involves humanity, birth and death, consciousness, relationships, suffering, and relief. It involves cultural awareness, spirituality, and our personal beliefs. Medicine does, of course, involve science, but so much more. So I went to Thailand to expand my knowledge of all of these areas to be a more understanding and compassionate physician. The traditional and complementary medicine clinic was unfortunately closed the first week of my visit, and I was reassigned, quite ironically, to work on an oncology service, which specialized in seeing cancers of various natures, including the brain. After a few weeks, I was finally able to work in the complementary medicine clinic, but of course woke up that day feeling like I was coming down with a cold. This was pre-pandemic, so I took some ibuprofen, threw on a mask, and decided to walk into work anyways. Since this type of experience doesn't really come along every day, and physicians sometimes make pretty terrible patients ourselves. My cold-like symptoms improved as I walked into clinic. As usual, it was a beautiful and sunny day in Thailand. I arrived there and was quickly brought into the Chinese medicine department, where a doctor asked me if I'd like to try out acupuncture myself. I had never tried it before and happily agreed. But as I lay on the table with needles covering my neck and back, I started to feel like I had a fever. Angry at my body for failing me, I took the afternoon off. When I returned home, I lay in bed and suddenly felt my left hand muscles and my throat muscles start to contract rapidly. This was odd, and I couldn't explain it at the time, but I drank some water, took another ibuprofen, and napped it off. I woke up the next day, went to work, and walked to a small local market on the way home to find a couple of souvenirs for my family. As I stood outside of the open air market, I felt that same awful muscle cramping start again out of nowhere. I stepped out of the tent I was in and hid between a couple of vendor stalls. My left hand started to contract rapidly again, squeezing my fingers together almost like a claw with no control over them. A few seconds later, my hand relaxed, my throat again closed up on me. I was scared, honestly. But 30 seconds later, muscles were all relaxed and I felt back to normal. I tried to medically rationalize this random and temporary muscle cramping that I had experienced. In my mind, I thought, this could be an electrolyte problem, maybe dehydration, an infection, or probably just anxiety. Oh boy, I felt like, I guess it could be a partial seizure as well. But why? It must be a pseudo-seizure, another word for an anxiety-provoked neurological event, but nothing real in the sense of seizures. As a then 29-year-old, otherwise healthy physician with no other symptoms and no reason for a seizure, I tried to just brush this off and decided I would worry more if it happened again. Well, it did happen again, about 5 to 10 more times, in fact. Couldn't brush it off any longer. And I would soon determine that these were indeed focal seizures, my body's one and only symptom of brain cancer. Literally a week prior, I had no symptoms of the huge tumor growing in my frontal lobe. I'd felt amazing, actually. I was volunteering at this elephant sanctuary, not a care in the world. When my scariest seizure occurred, it was late in the evening in Thailand. Their emergency medical system works quite differently, and I was not excited about the idea of spending a full evening sitting in a triage center without being able to describe my symptoms in the Thai language. Instead, I called my emergency contact at the Chiang Mai University, a physician I had worked with there, who very fortunately happened to be a neurologist. I described my symptoms to her on the phone late that night, feeling like a fool bothering her for what was likely nothing to worry about, but I tried to explain my symptoms as a doctor would, consulting another doctor on a very strange case. This strategy actually worked. She agreed with me and told me to meet her the next morning to go into her neurology clinic. The next morning, she brought me to the neurology clinic and left me alone in a busy waiting room. While waiting, I planned out the story I would tell the neurologist. If this clinic worked in a similar way to the one I had worked in the previous week, I knew I would have roughly 2 to 5 minutes to explain my symptoms and convince the doctor that the symptoms were real and not just the anxious manifestations of a very young hypochondriac. I would then advocate to get an MRI scan of my brain. About an hour later, with my palms sweating and my voice shaking, my name was called. I walked into the clinic room, and here I was, both patient and doctor, for the first time in my life, unsure of my identity or how I should act. I told the neurologist my story. I said I knew these symptoms could just be anxiety or my imagination, but I was confident I had enough signs pointing to seizures that I needed an urgent MRI. The neurologist looked somewhat quizzically at me, not quite sure what to make of a young, somewhat bossy American physician sitting in front of him, diagnosing herself with seizures and requesting a specific workup. I thought I must sound completely crazy. The neurologist had me do a brief exam, one I was quite familiar with, and as it progressed, his expression changed. We realized together that my left hand actually displayed some slight weakness compared with my right. Our shocked eyes looked together, and he said he agreed with an MRI. A nurse took me back to the MRI room, gave me a gown to change into, and asked me to sign a financial agreement. In Thailand, payments work much differently than in the US. Medical quotes are all predetermined, and patients are asked to sign agreements before their procedure or treatment even begins. I signed a bill agreeing to pay around $250 for my MRI, and I lay down on the table. Compared to the MRI machines at home, this one was large, scary, and kind of frightening. I didn't receive any headphones playing any relaxing music, and I wasn't offered any medication to curb claustrophobia. Instead, the technician played some intense Thai pop music and left the room. Lying there in the MRI, I decided I must be losing my mind, must be having panic attacks, I told myself, only to start feeling my left hand cramp and my throat muscles start to tighten. I lay in that scanner for 45 minutes before the tech came back into the room. Expecting him to say I was finished, I was surprised when he instead asked me to sign a second financial agreement. In limited English, he said, "Is it okay if we charge you for a surgical planning MRI now?" "Excuse me, surgical planning MRI? I assume this means that you found something." "Yes," was all he said. Keeping my questions brief due to our language barrier, I asked him, "How many masses did you see? One or many?" "One mass," was all he said. I agreed to pay the money and spent the next and longest 20 minutes of my life thinking about my possible diagnosis. Possible diagnosis for one brain mass leading to recurrent seizures. Brain infection was first on my list. I'd spent days playing with beautiful but very dirty elephants. At one point, I'd even hopped in the stream to bathe them. No doubt I had caught some terrible infection that invaded my brain. I wondered how I could have been so careless. Next on my list was a camera smudge. I was lying in an outdated MRI machine with old computers around me. Thought this must simply be a technical glitch and a big misunderstanding. The inner patient in me didn't want to consider the last possible diagnosis on my list, but the inner doctor in me knew I must. A brain tumor, one mass, and one life-changing realization. I realized the neurologist I had met earlier that day told me he would not have time to read my scan until the next day, but with a life-threatening infection on the list, I knew this wouldn't do. I got off the table and walked into the technology command center, feeling terrified, yet confident that I needed the greatest bravery of my life. I told him, "Sir, I'm a physician. I need to see my scans and take a few pictures." Being the only doctor in the imaging center, the tech agreed and moved aside. On the screen in front of me, as you can see here, I saw an enormous, golf ball size, irregularly shaped mass in my right frontal lobe. The mass was so large it actually caused minor mass effect, meaning that the tumor was smushing all of my healthy brain tissue into the left side of my head. I snapped a few photos with my cell phone and tried to process what I was seeing on the screen in front of me. My first thought was, well, shoot, I'm going to have to tell this patient some really bad news today because she has a massive brain tumor. The radiology tech said, "All right, that's enough time," and abruptly kicked me out of the room. "The radiologist will call you tomorrow." Speechless, I left the clinic. And there I found myself, standing on the sidewalk in Thailand, trying to process what I had just seen on my own scan. The doctor in me knew this was either a tumor or less likely an infection, both of which could be considered medical emergencies. So I decided I needed to be admitted to the hospital. I shouldn't be standing alone on the sidewalk in Thailand waiting for a bigger seizure to come along and kill me. I texted a picture of my scan to my neurologist, told her it looked like a tumor or an infection, and I requested a hospital admission. She agreed with me, and that's how I found myself a patient in Thailand. I was a patient in Thailand for 3 nights. Although the medical care system works differently in Thailand than in America, really many of the basic logistical and scheduling aspects of the hospital stay were very familiar to me. I knew that the physician would order some labs and vital sign checks, so I was prepared when the lab tech came into my room, stuck an IV in me, and took some vials of blood without saying a word. I was also prepared to be woken up from sleep every couple of hours for vital signs, monitoring of my heart rate, blood pressure, and oxygen levels. Every time a familiar activity happened, I felt grateful. All right, I know what this is. I can feel this blood pressure cuff squeezing my arm. I can read my blood pressure measurement, and I know it's okay. When an IV pole was wheeled into my room and fluids were hung next to me, I thought, all right, this is a familiar fluid. I know why the doctor ordered this, and I know what effects it will have on me. None of this was explained to me as it was happening, partly because of a language barrier, but really more honestly because none of this is explained well to patients. As a doctor, I often make the decision to order labs, start IVs, start fluids, and do vital signs without telling my patients. Of course, I always tell my patients of critical changes in their treatment plans or test results, but routine tasks like these are as commonplace in medicine as sending an email might be in the corporate world. Physicians don't always remember that for patients, an email feels very different than a blood draw or a blood pressure measurement. I absolutely can't imagine how terrifying it would be to be a patient, let alone in a foreign country, lying alone lying alone in a hospital bed without any knowledge of why these things happen, when they happen, or what the results might mean. The only reason I felt comfortable at all is because this is literally my day-to-day job. I can't imagine the fear a patient would feel experiencing these things with no framework of the way hospitals work. I tell you all of this not because it's how medicine should be, how it always is, or always will be, but because I can't deny how grateful I felt to understand this situation through the eyes of a physician. Being a patient is absolutely terrifying. As a patient, your freedom is gone, you find yourself with a million unanswered questions, and you spend hours waiting for a doctor you just met to tell you the worst news of your life. I hope that I always remember being a patient with absolute clarity, so that I may be a more compassionate doctor to my own patients. In the end, one of my greatest gifts of my cancer experience has actually been my experience being a patient. Through this, I've learned to be a much better doctor. 3 days after my diagnosis, my colleagues in Thailand and Minnesota arranged for a medical evacuation flight to take me directly back to the University of Minnesota, where I worked for an urgent brain surgery. I woke up in my hospital bed the next day, realizing it was my last day in Thailand. My journey had come to an abrupt end, although when I think about it, really my journey was only just beginning. My work previously with the palliative medicine clinic in Thailand had introduced me to an incredible team of nurses, doctors, and social workers, all experts in tough conversations about chronic disease, death, and dying. Miss A, pictured on the right picture above, was one of these superwomen on the palliative care team. Miss A and a group of my palliative care friends visited me. They laughed with me, cried with me, ate with me, and most importantly, listened to me. Prior to my hospitalization, one of the things I had most looked forward to in Thailand was the opportunity to have what's called a monk chat. Many temples in Thailand advertise times when monks are available to have informal chats with interested visitors. These chats offer a very casual experience where people can ask a monk anything that they think could be helpful. I'd had monk chat written on my calendar every single day since I arrived in Thailand, but kept postponing it for other adventures. In preparation for my eventual monk chat, I kept a list of questions on my phone, including such things as, what's one thing worth giving up to relieve yourself from suffering? And how do you find happiness in a world filled with suffering? Lying in the hospital bed that last day in Thailand, I realized I had never made it to my monk chat. As I looked at these questions, I started to cry. At that moment, more than ever before, I needed guidance. I needed answers. I needed a way to find happiness in order to cope with unexpected suffering. When the palliative care team stopped by again later that afternoon, they asked if there was anything else they could do for me. One common role of a palliative care team is to provide spiritual guidance for a patient when requested. In America, palliative teams often help coordinate with chaplains, or they call in priests to administer last rites. In Thailand, there are not many priests, but there are many monks. I asked my palliative care friends for one favor. Can you ask a monk to stop by and talk with me before I leave? An hour later, a middle-aged monk in this bright saffron robe walked into my hospital room and sat down, with Miss A following behind. He spoke some English, but Miss A was there to interpret for us when needed. I sat across from him and told him about my tumor. He listened to my story with hands resting calmly on his lap, smiling and laughing the whole time. After I'd finished, the monk spoke in English, summarizing everything I needed to know about life in 2 minutes. In these 2 minutes, the monk, whose name I can't remember, said to me, "Be happy." I nodded, unsure of what to say. "Find time to calm the mind," he said. I let this sink in. Be happy? Had this monk forgotten him? I just told him I had a tumor? He went on to say, "This happened for a reason. Smile. Do not cry." Hearing this, of course, I burst into tears and smiled foolishly at the same time. Every emotion was going through me: fear, happiness, sadness, terror, and joy. The monk saw my tears and said, "Don't worry about your illness. Illness and death are a natural part of life." I had never felt the kind of deep inner peace I felt when the monk spoke those 2 brief sentences. Illness and death are a natural part of life. As a physician, I knew this, of course, yet I'd never actually considered that this fact of life also applied to me. I'm young and healthy. Why would I be dying? How foolish, I realized. We are all dying. Death had found me, and I was not prepared for it. The monk was right. I have had what feels like hundreds of years of schooling, yet nothing in my education was as helpful to me as this monk's brief lesson. As a physician who has seen illness and death more times than unfortunately I can count, I can tell you without a doubt that only one thing is medically certain in this life, and that is death. Why fear the inevitable? Why keep quiet about death when every human being in the world will experience it? Humans, especially in the West, don't like to talk about death very much. It's almost as if we think we can ignore death, and that way we can avoid it. Yet we know deep down this is fiction. Death will find us eventually. Perhaps if we become aware of our mortality, we can learn to find happiness with the time that we have. At least that's what I've learned. Well, a lot has happened since I returned from Thailand last February, including 2 intense brain surgeries, a diagnosis of anaplastic astrocytoma versus secondary GBM, and standard of care treatment for astrocytoma, including 30 cycles of radiation and 6 months of adjuvant Temodar. After finishing radiation and chemotherapy, I have been incredibly fortunate to have had stable scans for the past few months. Although I do not have glioblastoma, anaplastic astrocytoma, or grade 3 glioma, is treated with essentially the same standard of care and almost always progresses to glioblastoma someday. I lost my hair, I finished medical residency, I wrote a book, I started to speak as a brain cancer advocate to raise awareness and resources for this devastating and somewhat common disease. I lived to see another day, and I found happiness. Sometimes I reflect on my recent experiences, and I wonder if all of this happened to allow me to help others in a more meaningful way than I ever dreamed was possible. Through dying, I've learned to live. Through suffering, I've found joy. Through the loss of the guaranteed future I once envisioned, I have found peace and freedom. I feel more alive today than I've ever felt before. My memoir is titled Difficult Gifts because that is what cancer has been to me. Cancer saved my life in many ways. Cancer is the most difficult, beautiful, and life-changing gift I have ever received. This difficult gift not only inspired me to write and share my story, it also taught me to be a better and more relatable doctor by being a patient as well. Thank you for listening. I'm happy to take any questions.
Thank you, Courtney. That's an amazing story. I can't tell you how much those details actually help probably not just patients, but caregivers as well. I know Dr. Glickman had a couple of questions. If you would like to go ahead and start, Dr. Glickman, with a couple of your questions, and then we'll go to Dee Dee.
Okay, that was, your story is harrowing because A, you are out of the country, B, you are a doctor and have a lot more insight than most normal, let's call them normal people without medical background. And C, the plight of any patient with glioblastoma or any disease that carries a lot of unknowns and a lot of fear is a difficult, it's difficult to deal with, whether you're by yourself or whether you're with your family, whether you're in the country, out of the country, at home or away. So I give you amazing kudos and you know, it's just amazing that you've been through it and you're making more of yourself because of it. So
Thank you.
You're welcome. What you've been through kind of leads into what I deal with on a regular basis as a neurosurgeon. And I basically have this narrowed down to about 3 major categories of things that any patient who is diagnosed with a brain tumor, or for that matter, any major illness. And I do like your quotes from the Dalai Lama, especially the one about that you know, the seed of death is planted at birth, and how we are, it's never timed. We're never ready. You can never, it's not like, oh, you know, you get a little whisper in your ear and it says, hey, by the way, you're going to have that heart attack next Thursday. So I think there's a commercial for some drug on the market where they use that. It's the same thing. No one ever tells you, gives you a heads up. You had some seizures and things, and occasionally in my practice, I see patients and they have had this prodrome of lingering symptoms that they attribute often to, well, I'm overworked, well, I'm tired, well, I'm stressed out, well, I'm just getting old, it's just mom, it's just dad, you know, he's been like that or she's been like that for years. And so you tend to overlook things even in yourself or in those closest to you. So, and then when it finally does get diagnosed by an MRI or by an EEG or on a CAT scan, whether you're in the emergency room in Thailand or you are, you know, at your primary care doctor's office or you wind up in my office, it doesn't matter. It's there. And when it hits, it hits. So I have this broken down into three major kind of categories. The second one being what I perceive, and of course with my bias as a neurosurgeon, to be the most critical. However, they're all equally fundamentally important. First is coping with your diagnosis. And this is something that, as I said, this is real and true for any disease. As an internist, correct? As an internist, you know, you have to break the news of you have diabetes to somebody. Well, that's a life-changing word for somebody who's not previously thought about being diabetic. Or you've had a heart attack. That can be a life-changing phrase for somebody who has not thought about having a heart attack, or et cetera, et cetera. There's hundreds, if not thousands, of diagnoses and things that we deal with as doctors that we have to break that kind of news to a patient and their family that is going to forever change their life. They can choose to grasp it and take care of it themselves, or and deal with it, or they can choose to let it deal them. So of course, with coping with your diagnosis come all the stages of Kubler-Ross, 5 stages of grief, etc. And I don't need to go into that because everybody has those. What I see often is you have those and you go through denial all the way to acceptance, and then you do better. And then sometimes, a lot of the time with glioblastoma in particular, it comes back around again. You finish your treatment, maybe you have a new MRI and it might set you back, and you go back to it's grown back, or it is, you have another seizure. And even though it might be great on imaging, you still have denial and then anger, et cetera, all the way through to acceptance. So that coping with the diagnosis, I think, is critical for anybody. And it's perhaps the most difficult for everybody. The second is building your team. Obviously, you were in Thailand, very difficult to do that. I'm glad that you had the contact that was a neurologist, and then you were able to get back to the US and get treated appropriately. It looks like you're doing fantastic. Building your team, again, this is what I perceive to be a critical step for a patient and their family. That team building experience includes the following people. And there's others as well, but the critical ones acutely are the surgeon, your oncologist, your radiation oncologist, your primary care physician, and a lot of time people don't have a primary care physician, but they're going to need one. The physical therapist and a rehab physician. And then the critical piece that's often overlooked is your family, who's your support structure. Because this is not a have an operation, get better right away, go home, you're all better, ta-da. This is a event that is going to forever be with you, potentially end your life, potentially save your life, but is not going to be over in a long weekend in the hospital. This is going to be potentially weeks, if not months, of surgery and hospital time, radiation therapy, chemotherapy that may last a few years. We have things like Optune, which is in an ongoing fashion. You have to wear this on your head. Ongoing physical therapy for deficits and deficiencies you may have. Your tumor was on the right side. You know, if had it been on the left in the same location, you'd have speech issues,
Exactly.
comprehension issues. So the physical therapist and the rehab, it also includes speech therapy and swallowing, the ability to communicate and eat, and perhaps getting off a ventilator. All of those components are critical, and the family members, whether they are friends, family, spouses, parents, children, cousins, aunts, uncles, you name it, need to be involved. As far as the third component, that has to do with the timing of all of this and advocacy for you as the patient. Timing means a couple of things. When you are diagnosed, one thing that I see very often in a lot of patients with tumors is they have, I just noticed that my video wasn't on, sorry about that. A lot of people with tumors is that they have a diagnosis that's made on imaging. I suspect a brain tumor. You suspected tumor or abscess. You know, when I saw the pictures that you presented, to me, that's a tumor. There's no question. However, the timing of it is critical. There needs to be time for appropriate pre-treatment, in some situations, medical optimization, cardiac optimization, clearance to make sure that people, you know, you're young and otherwise healthy. People are in their 70s and have hypertension, diabetes, hyperlipidemia, and everything else that goes along with that. They might need some additional optimization. So getting the surgery done in a timely fashion is critical. Putting people on steroids, as we most often do when a patient has a diagnosis like suggestive of tumor, is we put them on steroids, and then they get better, they feel better, they start to eat better. Some of their symptoms may go away or resolve completely. And there's a bit of a halo effect that these people have. They feel, oh, I'm all better. The medications the doctor gave me made me better. They're not having seizures anymore because they're now on some anti-seizure medicine.
Mm-hmm.
That's for the average person, they just don't know. So getting the surgery done in a timely fashion is critical. That steroid effect only lasts about 2 weeks.
Right.
That's kind of the sweet spot, about 4 to 10 or 12 days. And after that, the steroid effect starts to wane and you wind up having a recurrence of your symptoms. And now you run out of runway. So getting organized and getting yourself planned and getting your family aware about what you're about to go through is critical. You have to tell people your goals and your limits for what you want done, and just in case, and you need to make that clear so you don't want to run into lots of problems. You deal with that as an internist, I'm sure, with your patients, you know, older patients and code status and what have you.
Absolutely. And I'm happy to speak more to that later as well. Actually, on my blog, I wrote about my own experience writing my own advanced care plan and healthcare directive, dealing with my code status and wishes at age 29, very unexpectedly.
Yeah.
Yes, very important to do that. Mm-hmm.
So, you know, telling the critical people in your life your goals, your limits, having, you know, either before or after you have surgery, when you are able, when you're able to voice that appropriately to all the right people. If it means formalizing a document, a legal document to give your wishes, that's critical. But what I would say is that the timing of things, building your team and timing of things is critical.
Could I jump in real quick,
Yes.
Dr. Glickman? Because I think that that's kind of part of the question that's really proposed here is, how did you build your team, Courtney? How did you time things so that you would be optimizing the best treatment for you based upon what Dr. Glickman has just talked about?
Mm-hmm. Yeah, absolutely. I absolutely agree. That's a very critical part of the treatment for any disease, any illness that will change your life in significant ways, right? You need to make sure that you're working with a team of not only physicians, but all of your healthcare support staff that is, will make your experience as easy as it can be. And you want to feel like you trust your team, I think is the key. For me personally, of course, I had an advantage being that I know many physicians in this space, and I could pick my team based on kind of who I knew I wanted to work with. So that's definitely one advantage. But what I would tell, my patients, if I were going through this and didn't have the connections that I did, is that you need to feel that you have a team that you can trust, who is there for you, and who makes you feel like you are able to advocate for yourself. I think those are key pieces. I also think it's really important to not limit your scope. As Dr. Glickman said as well, you will have many people on your team. You'll have likely a surgeon, at least at some point. Again, timing can vary depending on where your tumor is, what meds you may need, what other treatments you may need before surgery. But a surgeon will be on the team. A neuro-oncologist will be on your team, a radiation therapist, many nurses, many pharmacists, many therapists. I could go on and on and on here. I think that there are a number of people that need to be on a team. And probably the place to start is some of this you don't have a choice, and it's an emergency scenario for a lot of people who are diagnosed with a brain tumor. So you get paired with a surgeon, you get paired with an oncologist, and you kind of go from there. And often those two physicians can coordinate the rest of your team with you. But what I will say is that I absolutely advocate for everyone to get a second opinion, get a third opinion if you need it. I think that if you feel any hesitation about the team you're working with, they may not be the right team for you. And you should absolutely not be afraid to do that. As a physician, I am not offended if my patients get a second opinion. I think it's really critical to make sure you're getting the right information. I also think, that as patients and as caregivers, as physicians, joining these support groups such as this one. I mean, I have joined so many support groups, and even though I know a lot of the medical information that is posted in these groups, I still find that community incredibly helpful to get other opinions, to hear about, new studies, to just hear what other people are doing and how they found the best team. So I think that's another important piece. And as you said, Dr. Glickman, family, friends, making sure you have your own support system is key. I personally have a great family and friend support system that I couldn't have gotten through, this diagnosis without them. I also see a therapist. I'm very open about that in my writing. I think therapy, if it's for you, is a very helpful thing to do. Or having a palliative care team, as I briefly mentioned, a team that can help you cope with your symptoms and help you cope with your diagnosis. So many things. I could go on, but I'll stop there for the sake of time.
Excellent. So go ahead, Scott.
So there's a couple things. So Courtney, the patient, she makes several points versus Dr. Burnett, the patient, sees this from a different perspective. And I think that is a unique viewpoint or bipolar viewpoint that Dr. Burnett and Courtney, being the same person, has in being able to see this, the side of healthcare. There's a movie from, I'm probably dating myself, I think it was in the early 90s, called The Doctor, William Hurt. And it was about how a doctor gets sick and then he makes his trainees go through the process of being patients themselves. And there's a lot of things that they experience that change them and the way that they treat their future patients or treat their patients after that fact. What I heard Dr. Burnett say is that, and I agree with this 100%, and I was actually going to say something about this, is, you're entitled to, despite it being an urgent situation, a new diagnosis of a brain tumor, to get a second opinion or get a third opinion. If you don't like your surgeon, or if you don't like the reviews they have, or if there's some concern you have, then you should seek a second opinion. If a lot of surgeons, even a lot of surgeons who take, neurosurgeons who take call at different hospitals around the country, they might not do brain surgery. They might not take out brain tumors. It's not a dire emergency. So their inclination to do anything about it may be low. To me, that is not acceptable. If you have a brain tumor, such as suggestive of glioblastoma, the only solution is to be aggressive. It's either be aggressive or don't treat at all. Because if you don't treat at all, you're just, it's better than treating a little bit, saying, well, we'll just give you some chemo and palliative radiation. You might as well be in hospice and at least be comfortable with it. There's no goal set if you are getting kind of a minimal or partial treatment. If you're getting if you have a surgeon that says, look, we need to be aggressive with this, but you need, as I said, as far as your goal setting and your involvement, you need to tell people, hey, look, I understand there's risks of surgery. I understand I might lose some functions, but I want to live. I want to I want to make sure that I can function with some independence and have quality of life that's going to give me extended years. Then what you need to do is you need to find a surgeon who is appropriately aggressive.
Absolutely, Dr.
Wow.
Glickman. And what I write about a lot is this idea of quality versus quantity of time. And for every patient, it's so important that you figure out what your own goals are, and use your own goals and express your goals to your family and to your caregivers to help you make a decision together about what is the best way to treat the situation.
Definitely. Dee Dee, I know you have a couple of questions here. Could you jump in for us and share those thoughts that you have?
Yes. So Courtney, thank you so much for sharing so openly about this, because I'm a longtime registered nurse and I've worked with oncology patients, but a lot of mine has been in home health. So that wide variety of patients. And like you said, nothing prepares you for this. We as a society just don't. For whatever reason, we just don't embrace death and illness. And it is guaranteed. That's something that's going to happen. And I appreciate what Dr. Glickman, what you say about, the urgency. But we also have to make sure that we have a team around us. And that's one of those things that I advocate for patients, is that it's very difficult, even when you know about healthcare, those simple things that you said about blood pressure, when they come in, they check your blood pressure. I can remember my husband being in there going, what are they doing? Why are they back in here? I can't sleep. I knew it as routine, but he didn't. And being able to help families navigate through that and going through all of that grief and that anticipatory grief that happens, and still being aggressive and getting some approach. But are there times where you feel like, in looking back, I know that we would all agree that it's urgent. We have to go in and we have to do surgery, but making sure that you have that team around you and having that more strategic than rushing into whoever the on-call is. And unfortunately, I think we see that, and they don't really look at the whole picture. Would you agree with that?
Yeah, I think that's a great point. I think that it's a tough question because it depends so much on everyone's unique situation,
right.
How this was diagnosed, how emergent the situation really is. And even for, various types of brain tumors, they all have such different, they can impact so many different functions depending on where they're located, the genetics of the tumors, et cetera. And so I think that it's a very tough question to answer overall. I guess I would say that if something is a true emergency, obviously there's less opportunity to choose your team in that moment. And the safest thing may be to go with whoever is available to help you with that particular situation. But I think my point is more, as you go along in your treatment journey, when you maybe are past that emergency point and you have time to sit down and really get to know the team that you've been assigned, if you don't feel that you have a good relationship with that team and there is time to get a second opinion, I think that that's worth doing. Okay. So I don't know if that fits to your
no, and I appreciate that, because it is very different, and this is not a cancer that follows a set pattern. There's others that do tend to follow a pretty consistent pattern, and this one is just so completely different. You mentioned the adjunct therapies and having that Eastern and that Western medicine training, I so appreciate. But if a patient wants to explore those adjunct therapies, do you have any recommendations on how to approach the physician? Not if we can, but how to have those conversations? Because I think a lot of families have that question, but they don't know how to talk to a doctor.
Mm-hmm. It's a great question. And I think that, in my personal opinion, I think that if you don't feel comfortable enough with your physician to ask, hey, I heard about this supplemental or adjuvant treatment online or from a cancer support group, or my friend is doing this treatment, is it helpful? You should feel like you can ask your provider that question. And if you don't, that may be a sign that you don't have a great relationship with that provider. Sure, there are definitely very different feelings amongst providers, even, if they believe in these treatments or find them helpful or useful or what have you. So I think the first step always, if a patient is thinking about adding on a treatment that they may have heard about online, there was a lot of information out there about supplemental treatments that may or may not help in glioblastoma, supplemental drugs, things like diet changes, exercise changes, what have you. There's so many thoughts out there about what could help. And we just simply don't have enough data to know yes or no for most of those things. I would say talk with your neuro-oncologist very openly about it. And for the most part, I think, many of those treatments, if there are no negative side effects or risky side effects, why not? I tried acupuncture, I get massages, right? I do things that they don't have side effects that are harmful to me. They may not have provable benefit in scientific studies, but if they make you feel good and they make you feel like you are taking control of a part of your life that's sort of been pulled away from you, why not? And I think you should have a provider that you feel like you can be openly discussing those type of subjects with.
Great. I appreciate that.
Can I jump in on that as well? I agree. I would split that into two different categories. One, as Dr. Burnett just said, massages and acupuncture and things that are adjunct therapies that I love it when my patients want to do other things. And even things like handfuls of vitamins. Hey, I like to be informed. Hey, doc, I read about this, and here's this yellow pill that I started taking. It's a vitamin and whatever. It winds up being turmeric or something. Great, fantastic.
Sometimes, although as an internist, that scares me with all the drugs I prescribe. So make sure you tell your doctor about that too.
Of course. I'd rather know to make sure that those medications are not going to, those vitamins or pills, whatever they're taking, even the therapies that they're doing, the massage and what have you, is not going to interfere in some way with chemo or some other treatment that they're going to have. Most of the time, quite frankly, they don't. They're wonderful adjuncts. The other side of that is, a number of years ago when I was in medical school, the drug companies decided that they're no longer going to allow, they're not going to give doctors pens and pads anymore, but they're going to spend 10 times that much money that they spent on that kind of advertisement, but they're going to directly advertise to patients, which is why we see so many commercials for drugs on television and what have you. The problem is I do have patients that come in and say, hey, doctor, I'd like to try this. And it's some therapy that's for psoriasis that they want to try in their brain tumor. And it's difficult for me to try and explain why that's not an appropriate therapy for, this. And inevitably, once in a while, I will get a patient who says, but I found this article that at Mayo Clinic or at MD Anderson, they're trying this medication on brain tumor. And that's fine. I'm aware of a lot of those trials. However, that's where we have to say, okay, fine, let's try and get you enrolled in that trial. So I do like it when patients are interactive and involved in their care. I don't want them to just take my word for it or their oncologist. They need to stay active and involved, as do their advocates.
Wow. Interesting. Well, I've got another question from a few of our board members. I know we're going to run short on time here, but Dee Dee, did you have anything else you wanted to ask?
I think the only other question that I had, Lisa, was, Courtney, for you as a patient, you have mentioned palliative care and the importance of incorporating that earlier than later. And I think it's easy for us to say as healthcare professionals that we know the benefits of that. Are you, while you're still working, is that a part of your treatment plan, if you don't mind sharing?
Very good question. So I'll be honest, at this point, I do not see a palliative care team, only because right at this very moment, I'm fortunate enough to have no symptoms that are incredibly bothersome to me. Mm-hmm. However, I absolutely recommend a palliative team to be a part of your treatment team for anyone with a brain tumor or with essentially a chronic and or terminal disease. Palliative, some people associate the term palliative care with hospice care, right, and they're not simultaneous. They're not synonymous terms. And so I think that it's important to think of palliative care as really, I describe the palliative team as experts in managing symptoms, experts in having tough conversations about goals of care and what you would want if X, Y, or Z were to happen. And I think having that team to help you with symptoms and to help you navigate is essential to anyone who is new to having, not involved in the medical world or new to having a chronic disease. So absolutely, I think that's a vitally important team to have, even if you're not ready to talk about something like hospice or foregoing treatments. I think that, they're not the same thing. And palliative, yes, can help you with those decisions too, if and when the time comes. But there's so much more that they can do as well.
Right. Thank you.
Well, I have a question here from some of our followers and board members.
Absolutely.
The first question is, how do you approach talking about your prognosis with those closest to you? And what advice do you have for others to navigate these conversations with their loved ones?
Great question. Tough question. I think for me, the short answer is when, about things like prognosis, simply put, we don't know. Nobody knows. Nobody has the answer to that. Yes, some people really strongly want to know the statistics and what historical studies have told me my prognosis will be. I can guide them to that information or be honest with them about it. But I think what we have to keep in mind as patients and as physicians is that studies that are published, that data was collected in the past. And so things are constantly evolving, especially in the field of brain tumor research. And so statistics are changing, and prognosis is a tricky question to answer. I can't know the answer to anyone's prognosis. Often in medicine, we talk about it, do you have hours to days, weeks to months, or months to years? And so often if someone asks me directly, that's the kind of way I'll frame it. Okay, with this diagnosis, I have, months to years, hopefully on the years side, right? Maybe more months, we can't know. But further than that, I have no idea.
Gotcha. Another question that we had is, did you notice changes in your brain prior to diagnosis?
Great question. I did not. And so really the only symptoms I had were these focal seizure symptoms that I developed about a week before I was diagnosed. I think it's easy to look back and think, could this vague thing that happened 5 years ago have been a symptom? Could I have known sooner? And from what I've, experienced myself and from what I've heard and read about as I've gotten to know a lot more, fellow cancer survivors and warriors in the community, is that I don't think anyone should think that they could have known sooner. I think brain tumors are sneaky. And sometimes they cause symptoms and sometimes they don't until they're enormous and causing major problems in the brain. And it just depends on location and type of tumor. So no, I don't think I did not have earlier symptoms. And I think that's true for many of us.
Interesting. I have another question, which is, what advice do you have for caregivers that would help them have a better understanding of this disease as a patient and on how it impacts your brain?
It's a good question as well. I think, I encourage caregivers to also join a lot of the cancer support groups, such as this one. I mean, there's many on social media. There are many that your neuro-oncologist can guide you to, or your surgeon can guide you to. And I think joining those groups to see the same information that the patient is seeing can be really helpful. I also, during pandemic times, it's hard for our loved ones to come with us to appointments. That may not be an option. But, and so if your provider is only seeing you virtually or over the phone, having your loved one or your caregiver sit with you on that virtual appointment, or asking your provider to give your caregiver a call and explain what we went through. I think those are really good things to do.
Gotcha. How do you, well, let's see, let's go with this other question here. I know we're almost at our end of our meeting, but the question that I had was, what do you do in terms of self-care and staying positive? So we kind of know some of those.
That's one of my favorite questions. I think that's key. I think, again, like I mentioned, of course, we can have a lot of answers for how we can, survive with a tumor or fight with a tumor. I think positivity is a big one. We can't necessarily study it scientifically, but I'm all about a positive attitude. And how do you keep that? How do you care for yourself and your mental well-being despite having a diagnosis like this? For me, as I've mentioned, I write. I found writing to be incredibly therapeutic. I'm also very open about what I'm going through. I find speaking and writing about my diagnosis and how I'm feeling helps tremendously. I think that for me, I can't imagine keeping these feelings bottled up and sort of just feeling like I have to live with it and having no one to talk about these things with. For everyone, that's different, and so that's not the way for everyone. But I think finding your own version of self-care is super critical, whether that's seeing a therapist, whether that's meditating. For me, as you've seen in this presentation, I practice Buddhism. Spirituality is very important to me. I do a lot of reading in that sense. I do a lot of meditating and sort of focus on mindfulness. And for me, that's kept me very optimistic and positive. But of course, that's different for everyone. But I think finding what helps you stay balanced is key.
Gotcha. There are a few people that have asked the same question that are relative to what the current treatment is, which is our standard of care, surgery, radiation, Temodar. What is your opinion of these?
Well, I think they're great if they work, and I hope that they work for most of us. Yeah. They're what we have. I think that it's an ever-evolving field. I know that there's a lot of great research going on into newer treatments, newer options all the time in this field, and so that keeps me optimistic. I think that they're good treatments, but of course, any treatment has its own host of side effects, and for some, side effects outweigh the benefits, and so it's a very personal decision as to what you want to do to treat your illness.
Gotcha. I think that might tie into the question with, do you think treatment should be based on DNA?
I think in a way it is starting to be. I think we're learning a lot more about cancer genetics, especially with brain tumors, and you'll hear things, and I'm sure patients and caregivers, you've seen things in your support groups about methylation status, IDH mutant. There's a whole host of other genetic variants in our tumors that we're learning more about, and it's helping guide many of our clinical trials. So yes, I think that ideally, our treatment someday will be based more along the lines of our genetics and our DNA, but will it ever be there 100%? Stay tuned.
I think Dr. Glickman has a question.
Just a point about that. I agree with Dr. Burnett. Glioblastoma is a very heterogeneous disease. Something that was mentioned a moment ago was, if somebody has this diagnosis and they ask, how long do I have? And that's something I get faced with. I get posed that question multiple times a week. You know, the statistics are just statistics. And if it applies to, I could tell you that the median survival for glioblastoma, all comers, all ages, is about 18 months. However, it is such a heterogeneous disease that the spectrum of, is completely wide. I have a patient who's 10 years out from glioblastoma who has no signs of disease. Her genetics of the tumor and the treatment, aggressiveness, and all the other chemotherapies, radiation, et cetera, makes her stick her fingers up at glioblastoma, right? Because she is clearly not following the statistics. So the statistics only apply to the masses. If it happens to you, it's 100%. If it doesn't, it's 0. So it's very difficult to apply statistics to any one person. If I'm trying to predict, in all of my patients, then the average would be whatever the average is. And the maximum is the maximum and the minimum is the minimum. But as we get more and more evolved and developed with our therapies, right now we're using Temodar as the primary chemotherapy. And it's timed better now than it was, say, when I started training and started in practice, as far as when we use it with chemotherapy, with radiation therapy. There's additional medications that we can tag team on top of that are either used with recurrent tumors or can be used, say, at the time of surgery. And it does not preclude using Temodar or any of the other medications and radiation therapy. So we're going to move quickly over the course of the next decade to genetic-based therapies where we'll take out tumor, or we'll actually maybe be able to do an MRI, a very high-powered MRI that's going to get us perhaps not genetic information, but MR spectroscopy diagnosis where we can see what kind of proteins and structures and chemicals are in the tumor and be able to use different medications that are going to be based on what we see on just an MRI, not even based on a biopsy. We might have to take a biopsy or maybe have to do a debulking, but we'll have drugs and drug delivery methods that are better than we have now at treating specific markers of disease. Right now we have correlations. We can say if you have, there are certain
it sounds like, it sounds like the technology is evolving, and so we will see more solutions in the near future.
The technology is evolving, not just in drug therapy and in radiation therapy, but in surgical therapies. The ability to take out more, more tumor. Right now, one of the number one things that we have in care is of people with glioblastoma is if you can get better than 95% tumor section, you have a far greater chance of longer term survival than if you can't. If you get 80% out, it's much less than if you had 95% out. So meaning if you have a better way of taking out more tumor, then you have a better chance of longer term survival.
Excellent. So, Courtney, I know that you have an engagement following this interview, and I really want to thank you for your time. Gail, I know you just jumped in and you actually hadn't seen any of the presentation. We have about 30 seconds if you want to give Courtney a quick question.
I don't have any questions at this time, but of course your time is so appreciated and so valued, and please keep working on it.
Yeah,
Absolutely. Well, thank you all for having me today. I'm happy to speak about this anytime. And, my contact info is here. So please feel free to reach out to me for any patients or caregivers watching if you have questions, not so much about your own medical care, but about, what I've talked about today. Thank you so much.
much appreciated, Courtney. Again, her book, Difficult Gifts, can be ordered online. And Courtney, you do have a blog that you post about once a month about her challenges. If you aren't following that, the blog is located, what is the?
It's actually this on the pre-order link on this slide. It's that same link. So elephantlotusbraintumor.com. Just skip the pre-order segment and that'll get you to the blog portion.
And of course, you know, I love to share your blog with our social media platforms. You know, it provides hope and insight. You are a beacon of light in a tunnel that can be dark. Having traveled that journey, I cannot thank you enough for providing the information that you did. For our panelists, Dr. Scott Glickman, for for nurse Dee Coley, and maybe we can do this again where we can get some more questions in, and I look forward to hearing from you in the near future.
Absolutely, happy to. Thank you all.
Thank you,
Thank you,
everybody.
Courtney.
Have a good day. Bye.